Okay. So today's webinar is discussing learning disabilities, which will specifically focus on dyslexia as the primary form. And we're going to talk a little bit about some background information about understanding, diagnosing learning disabilities, some of the neuroscientific and neurophysiological understanding of dyslexia specifically. So neurofeedback research that's been done on the topic. And a new study we did that was just presented at the ISNR conference about looking at learning disabilities specifically. Again, if anyone has any questions or any concerns, feel free to just use the chat feature that's part of this. And we'll go from there. Okay. Let me just change one thing here. So I think I should be able to see everything okay. I'm just going to share it one more time. Okay. Again, if anyone has any difficulty, send a message via chat, or if you have questions, and we'll get to those throughout the webinar. So as of 2004, at least in the United States, the diagnosis and classification of learning disability was based on the following criteria, and that stipulates that a child does not achieve adequately for their age, or does not meet state-approved grade level standards in one or more of the following areas. Prior to this time, it was very common to use what's called a discrepancy analysis, which as of 2004 became illegal. And I think we'll talk in a few minutes about what that was, but basically at this point in time, or since 2004, to diagnose a learning disability, a child has to show a difficulty in any one or a combination of the following areas, including oral expression, listening comprehension, written expression, basic reading skills, reading fluency skills, reading comprehension, mathematical calculation, or mathematical problem solving. And it just has to be below a standard for their age. What that standard is varies from state to state. In some states, it can be 1 year delayed, 1.5 year, or at least 2 years delayed. And in other states, there's this notion of what's called response to intervention, where they will apply an intervention, say for a reading problem. If a child does not improve, they'll apply another intervention. And if they're still not improving, then that's justifiable grounds for them being diagnosed with a learning disability. It's also stipulated that this learning disability is not a result of a visual, hearing, or motor disability, mental retardation, emotional disturbance, cultural factors, environmental or economic disadvantage, or limited English proficiency. So those would be rule-outs. Based on the Child Trends Data Bank, this was done in 2014 for retrospective data. The total of all types of learning disabilities, prevalence in the United States, again, most of this research is focused on the US, is approximately 8%. Overall, males show quite a bit greater prevalence than females, almost a 2-to-1 ratio, and the male ratio is about 10%. These varies from study to study. In other groups of data from the National Disability Learning Centers done in 2001, they show of all children receiving services in school, almost half of them or for what's called specific learning disabilities, or SLDs, which can certainly include any one of those areas we discussed, plus combinations of those. And in fact, most learning disabilities are combined deficits, not isolated deficits. Okay, so as we talked about earlier, it was common in the past to use what's called an IQ achievement discrepancy. So, for example, an IQ test would be administered, and say someone got a 100 on an IQ score, then an achievement test would be administered, and if they had 80 or below, then they would be considered to have a significant discrepancy and a learning disability. The problem with this approach is that children with lower than average IQs frequently were not diagnosed with learning disabilities because they did not show a significant discrepancy. And also, children with higher IQ levels would not have to show the same low level of achievement scores to reach that criteria as well. So, as we talked about earlier, from 2004 on, this has been ruled out. And now what we do is we calculate an expected grade or age equivalent. And you can see, let's see if I can get a pointer here. There we go. So you can calculate this by calculating their IQ based on their chronological age and subtracting 5 years, because we don't expect them to have learned anything in the first 5 years of life, at least in terms of these ability areas of reading and writing, spelling, and math. And then we get an expected grade equivalent. Most expected grade equivalents are similar to their actual age. So if they're 9 or they're 9.2 years when they take that test, we expect them to function at that level on their achievement and learning scores, but not necessarily depending on their IQ score, as is indicated in this calculation. We then develop what's called a learning quotient, which is their expectancy, their actual age versus expectancy. So in an achievement test, you can actually get an age or grade equivalent score, say in that case, a 7.6, that we can compare to their expected equivalent of 9.2 and determine that that's a significant delay. So currently, that is one method for determining a learning disability. The response to intervention is the other major approach. Okay. As a result, the diagnosis of learning disability can only be done by those two methods, either neuropsychological, cognitive, and educational testing, or in some areas and states, this response to intervention idea. When it's done based on testing, they must show a significant delay compared to what they're expected to perform. We can no longer use an IQ achievement discrepancy score. A learning disability cannot be diagnosed from neuroimaging. And importantly, a learning disability cannot be diagnosed from a QEEG. So if you have a QEEG and you have a discriminant function that suggests they might have a learning disability, that is all well and good, but is not sufficient to actually diagnose a learning disability. Okay, moving on from there. Let's talk about specific types of learning disabilities. Back in 1981, there was a book chapter published by Paul Satz and a student of his, Robin Morris, at the time. Dr. Satz was actually my mentor about 10 years after this, where they looked at 236 students tested with educational and neuropsychological measures that they then subjected to cluster analysis. Cluster analysis enables us to take different test scores that line up with each other and put them together so that we can understand ability levels and areas. Achievement variables were put into two groups made up of 89 students out of the 236 that had very low scores, And those two groups were low in reading, spelling, and math by at least 2 years. So that was their discrepancy that they found at that time, or their delay. Neuropsychological variables based on the cluster analysis grouped into 5 different subtypes. They include students that were low in language measures, measures of verbal fluency, vocabulary skills, comprehension. The second group was those that only were low in verbal fluency. The third group were those that were delayed in language and visual perceptual abilities, both. There was a fourth group that was only delayed in visual perceptual abilities and not on language scales. And then there was a fifth group that showed no impairment. Groups 1, 3, and 4 showed more positive findings related to either achievement testing or actually neurological screening. So essentially we emerge from this with the idea that there are different clusters of learning, of cognitive findings related to learning disabilities. One being a group that shows mainly delays in language processing and functioning. Second, a group that shows mainly delays in visual perceptual processing. And third, a group that shows both. And we'll talk more about that as we move forward. So in terms of types of learning disabilities, people have spoken about dyslexia as the primary, but also dysgraphia, which is a delay in written expression, dyscalculia, which is a mathematical deficit, and nonverbal learning disability, which is a specific pattern or symptom cluster that includes mathematical deficits, sometimes written expression, social skills, some emotional difficulties, problem-solving, motor delays, very distinct from other types of groupings. Okay. So now we want to break that down into learning disability subtypes based on neuropsychological or cognitive dysfunctions. So in our primary group of dyslexia, which covers most learning disabilities, of course, there's a primary deficit in reading and/or comprehension, and typically what we see are deficits in either visual form perception, semantics, comprehension, or phonology, or any combination of those deficits. In dysgraphia, or writing delays, we see problems with visual perception, visual motor integration, or visual spatial organization. In dyscalculia, basically mathematical deficits, and we see problems in visual form, visual discrimination, and also executive functioning related to problem solving. With spelling deficits, we mainly see visual form deficits, sequencing, lexical, semantic, and/or phonological deficits. And with combinations of these, you're going to see combinations of neuropsychological impairments. The idea here is that the neuropsychological impairment underlies the learning disability. So if you have a deficit in auditory comprehension, you may also have a deficit in reading or reading comprehension. And one is considered to be the cause, if you will, or the precipitating event of the other. Okay. I don't see any questions, so we'll keep moving on here. The primary type of learning disability we're going to talk about is dyslexia. Of course, dyslexia is a delay in reading achievement as measured by individually administered standardized tests of reading accuracy, fluency, or comprehension, and is substantially below that expected given the person's age, intelligence, or other educational variables. The disturbance significantly interferes with academic achievement that require reading skills. And if a sensory deficit is present, like visual or auditory, the reading difficulties are in excess of that would be expected from that sensory deficit. Someone asked if we could have the PowerPoint slides at a later point, and we can certainly make arrangements for that. So thanks for the question. Okay, moving on in understanding dyslexia. So there are three basic systems that have been identified in understanding the components involved in reading. We'll talk about these one by one here. So the first is the visual word form area, which is located in the occipital association, or occipital to posterior temporal junctions of the brain. And this is the area that basically interprets a word for its visual form. It doesn't necessarily tell us what the word is or the meaning of it, but it is our visual perception of that word form. The second basic area the information travels to is the word analysis or semantic area of the brain, which is primarily located in the parietal temporal junction, very close to Wernicke's area, the parietal area, and an area called the angular gyrus that is very important for word processing, and that gives us our semantic word analysis. So that area of the brain, in combination with the word form area, tells us we've seen a word, deciphers what that word is, and potentially the meaning of that word. There is then another area towards the frontal posterior inferior portions of the frontal lobe that basically is involved in the phonology of that word such that we can pronounce it. We can either say it silently or out loud, and we have a full articulation and phonemic analysis of that word form. And without this, we're left without a conscious verbal referent to that word, even though we may have actually seen the word or may even have a notion of its meaning, but we still don't have the word being said, again, either silently or out loud. And these are the three primary areas involved in reading. And dysfunction in any of these functions will lead to reading or reading comprehension deficits. This is a little more complex rendition of what we've just gone over. This is from a meta-analysis showing areas of dysfunction in dyslexic subjects compared to normal controls. And each of these areas you'll see in turn, first the occipital temporal junction you see here, which is basically the word form analysis we've talked about. The middle temporal gyrus, which is involved in hearing and processing words. The angular and middle temporal gyrus, which is very close to the semantic processing area, and the inferior parietal cortex, which is involved in that as well. So if we were to draw a circle, which encircled this entire area, this would be our semantic processing area. But you can have deficits in semantics for different reasons based on where the processing deficit occurs. And then, of course, we have the phonology area, which is located very closely to Broca's area. And there is interplay with that in the anterior temporal lobe as well, but most of it occurs either close to or adjacent to Broca's area. And again, with deficits in any of these areas or connections between these areas, which is very important, you can have reading deficits. As you can see, this brain image points to the left-hand side, and almost all versions of dyslexia, at least primary dyslexia, are associated with left hemisphere dysfunction. Okay. Moving on from there. So the top image that you see are fMRI studies showing different combinations of individuals with dyslexia. This is in an fMRI machine on a reading task, showing activation here, for example, in the visual word form area, but not in the semantic or phonology region. So this individual is not going to be able to put together what they see with the meaning or the sound of it. Here we have another example of someone that activates the phonology region, but not the semantic or word form area. They might be able to sound out words or even repeat words, but will probably not be able to sound them out based on looking at words. And here we have a third example where we have activation of the word form area and the phonology area, and even a portion of the middle temporal gyrus, but not the upper semantic area. So the word form and its meaning would probably not be formed very well in that case. So you can have multiple different combinations of dysfunction in different brain regions, and they will result in the same reading deficit. Here you see a basic connectivity diagram showing pathways from visual inputs to the word form area, to semantic areas, to phonology areas. And basically any disruption in any of these links in the chain can lead to reading or reading comprehension problems. And frequently when we see an individual, we like to use QEEG as specifically connectivity metrics to see what we're dealing with and where this is breaking down for that individual. Okay, moving along here. This is just a rendition showing you that most learning disabilities are actually mixed specific learning disabilities. So when we see someone with dyslexia or reading deficits, they will also almost always have reading comprehension problems, and they may also have writing and spelling problems as well. We can also have a group, as we learned from Sachs and Morris, that has primarily visual perceptual deficits. And they would be likely to have problems with mathematics, writing, and possibly spelling functions as well. And of course, we can have a completely mixed group that shows both verbal processing and visual processing deficits, and they will have a combination of virtually all academic areas. And it's important to understand, of course, the type of difficulty you're dealing with when trying to help such individuals. Okay. Treatment intervention. So this is a listing of the different types of interventions that have been considered related to learning disabilities and their level of efficacy. And the bottom line of all of this is that there is no one specific approach, and most approaches have very limited efficacy when it comes to remediating learning disabilities. There's no efficacy at all for medications. Education as usual, in other words, not adding to their education in some way with some special services, doesn't seem to help. Resource room intervention by itself actually does not seem to be very helpful if someone is delayed in academics. And learning disability training programs specifically have been shown to be minimally beneficial. Even well-known programs like Fast Forward and Linda Mood Bell and Orton Gillingham applied to dyslexic individuals can have some benefit over lots of intensive therapy over a long period of time, but even that level of benefit has been shown to be fairly mild. And then, of course, we want to know about neurofeedback. And in fact, there's very little research done demonstrating that neurofeedback can be effective for learning disabilities either, although there are a handful of studies that we will talk about. Okay. So we just pretty much had a summary of those. We'll move into the neurofeedback studies that have been done. Most of them are case studies or case series. The first group-based statistical studies were done in 2003 and 2004. and there's been only a handful, maybe 5 or 6 at this point, of group control-based studies. So one of the first to emerge was that of Orlando and Rivera, published in 2004 in the Journal of Neurotherapy. They did neurofeedback on their subjects. They had an experimental group which received neurofeedback and a control group which had their education as usual. Neurofeedback was based on their written explanation on QEEG findings. And from the reading of the study, it looks like they did power training, although the details of that are not readily available. They did training over about 30 to 45 minutes per session. The sessions were done weekly over a 7-month period of time, and the average number of sessions was about 28. They did show that neurofeedback was more effective in improving scores on reading tests than not receiving neurofeedback, and they showed that that was significant for basic reading, reading comprehension, and reading composite scores. So this was really the first study of its kind to show that neurofeedback at all could improve reading scores. Another study that was published just prior to that, actually in 2003, by colleagues actually in Cuba. They studied individuals with learning disabilities, measured their QEEG. They had 10 children that were selected that showed higher than normal ratios of theta to alpha, absolute power. They did TOVA tests and IQ testing, but never did any educational testing, which is really the great limitation of this study and very unfortunate, because they did show a significant change, and in fact, they did show a significant change in the EEG. They also have done follow-ups to this and have shown that those changes have lasted, but they never actually did reading, writing, math, or spelling scores. So we have no way of knowing what the change would have been in the learning abilities of these children. Then we waited about 6 years for the next major study to look at information, and that was by a group in Belgium, where they studied 19 individuals, again, diagnosed with dyslexia. They had 10 of them assigned to a neurofeedback group and 9 to a control group. Both groups also received remedial teaching. So the control group had just the teaching. The experimental group had the neurofeedback and the teaching together. They did QEEGs compared to a normative database, and interestingly, did coherence analyses based on pairwise coherence metrics, which if any of you have heard me talk before, you know about there being some concern about that. And they did not find that any of their dyslexic subjects showed a dysfunction in the left hemisphere based on coherence analysis. So from what we've just spoken about, in that we would expect that to be the case, we think something is not quite right there already. What they did show is that there was hypercoherence over the right hemisphere. So they basically trained that down, and they showed that the groups improved in terms of spelling scores, but not in terms of reading at all. It is my hypothesis that with a different coherence analysis, they would have gotten different findings, done different treatment, and may have shown different results. And in fact, they did share some of those QEEGs with us, and when we do what's called a multivariate coherence analysis, you get very different results, and you can see the dysfunction in the left hemisphere that you would hope neurofeedback would help with reading more so if you applied the treatment in that way. Okay. The next study, which was published in 2012, looked at a single subject design over 6 children who were the participants between ages 8 and 10. They completed 20 30-minute sessions of neurofeedback with follow-ups afterwards. Again, they did not measure, they did. They measured improvement in reading and phonological awareness skills, and they were able to show, based on their EEG analysis, that there was what they called a normalization of coherence in different bands as a result of the training, which led some, including us, to postulate that if you work directly with coherence, you might be able to improve those aspects even more so. So we did a study shortly after that. This is the first study we'll present, and then I'll show you a second one after that. Let me just stop for a second, see if we have any questions. Okay, we're doing great. So let's keep going. Okay, so in this study, which should be published in the next, come out in Neuroregulation in the next few weeks, so you'll all be able to access a copy of that. That journal is open access, so everyone will be able to read that, print it out, distribute whatever you wish with that. For this study that was conducted in our New York clinic, we had 42 school-aged participants. They were randomly assigned to experimental and control groups. The experimental group received QEEG guided, individually tailored, 2-channel coherence training neurofeedback over the left hemisphere. I know that's a mouthful, but basically what we did is we did neuropsychological educational testing with them and QEEGs. We looked at multivariate coherence analyses. In almost all cases, it showed left hemisphere low coherence. We then developed 2-channel training coherence protocols to increase coherence, which we hoped would remedy some of their difficulties. They received 2 sessions per week. The sessions are about 20 minutes in duration for a total of 20 sessions. So we're talking about 7 hours in total of neurofeedback. The control group they were compared to received typical resource room instruction. So they were in their regular education. They were all also in resource room, and they continued to receive that assistance, but they were not receiving the neurofeedback. All participants, as we said, had pre and post educational measures focused on reading fluency, and reading comprehension. When we compared the 2 groups, there were no significant differences in any demographic variables. Following the intervention period, the 20 sessions, which took 10 weeks to finish, the experimental group enhanced their reading scores and the control group did not. Coherence neurofeedback led to an average enhancement of 1.2 grade levels in reading scores, and resource room instruction led to no such improvement. So that's a summary. Let me show you a few more details here. Okay, so I'm just going to stop and answer some questions as I go if I can. Someone asked why we used 2-channel training at that time instead of 4-channel training. So that's someone that knows the next study we're going to present, which is on 4-channel training. When we did this study, 4-channel training had not yet been created. So the data collection on this was about 4 years ago. Following this, we'll talk about the 4-channel training that we now do, and some data related to that compared to this as well. But at this point in time, we were doing 2-channel training, and that is what we will focus on at this point in time. Okay. So here's some of the, here's some of the demographics. You can see the ages went from about 9 to 15. They were mainly right-handed and mainly male, and mainly Caucasian. The vast majority were not taking medication. as you can see down here, although some were on one medication at least at the beginning of the study. Again, when we compared these between the two groups, there was no significant difference on any of those variables. This is a representation of how the neurofeedback was organized. So when you see a line, for example, that has a ball on one side, a line, and then a ball on the other, the balls are the two channels where they were placed, and that's how the neurofeedback was done. So in this example, you're probably looking at O1 over to maybe T3, or maybe even slightly posterior to T3. And these were each of the protocols. So you can see the grouping in blue, we basically trained from the visual word form area to the temporal lobe, which could include phonological and or semantic aspects. The red group trained largely from the semantic to the phonological, and the green group had different combinations. And again, all of the training was over the left hemisphere, because that's where all of their deficits were shown on their QEEG. Okay. So here's our two groups, the coherence versus the resource room group. And this is initial reading delay scores, where there was no significant difference between the groups. These are descriptive statistics of reading age 1 and reading age 2. So reading age 1 is the pre-score before the intervention. Reading age 2 is the post. So if you do the math here, you can see the coherence group improved by about the 1.2 years we talked about. The resource room group didn't show any change. And that's revealed in the ANOVA, showing a significant difference at reading age 2 between the two groups. If we look at a plot of the means of those changes and their standard deviation, you can see that the resource group basically had no change at all, and the coherence trained group had an average improvement of 1.2 grade levels that within one standard deviation varied from about 1 to 1.4. If we then look at percentage change in reading score, so let's say someone was behind by 3 years and they changed by 2 years, that would be a 67% jump, if that makes sense to everyone. Again, the resource room group hardly changed at all. The coherence change group in 20 sessions changed by 40%, almost half. Okay. When we look at the effect size of the intervention, we can see that is significantly larger than some of the other reading studies, the neurofeedback, and the reading intervention studies that have been looked at in the past. So I wanted to give an example for those of you that are not familiar with what we mean by multivariate coherence, because you will get a different result when you calculate multivariate coherence versus pairwise coherence metrics. And in many pairwise coherence metrics, like we talked about in the Belgian study, you can actually miss the problem altogether. So multivariate coherence, this is one version from what's called the NeuroRep software, will show you all combinations of electrodes and their coherence and how they all relate to each other. And in this example here, what we see is an area of low coherence over the left hemisphere right there, showing that the semantic area, which would be here, is not well connected to the phonology area, which is probably not well connected to the visual word form area. And we can look at this and conceptualize it, and then come up with a protocol that would enhance coherence across that area, then we hope leading to increase in reading abilities. So that's what we look at. There is also another, another newer way that we've started to calculate multivariate coherence. This is referred to as Granger causality, and it's basically processed through an independent component analysis, which you see here, which can then be source localized to dipoles, which are very similar with, if many of you are familiar with Loretta or S Loretta or E Loretta, this dipole analysis is a little bit different, but similar in some ways. It's basically an inverse solution to tell you where the surface activity from the EEG is localized into the three-dimensional brain structure. From that, we can pick dipoles of interest, given the fact that we know this person has dyslexia, and we know that their multivariate coherence up here showed this left hemisphere problem. We can choose the dipoles of the left hemisphere and then run what's called a Granger causality analysis on this and show that lines in dark blue and that are thinner and have smaller hubs are lower in coherence. So we designate sort of a triangle here, again, of low coherence from the anterior temporal region back to the semantic area and close up to where the phonology area would be in the frontal lobe, and again, decide to train coherence across that area. So it's another way of studying and understanding the multifactorial relationships in the brain as opposed to just one site to another. Okay, let's go down from there. Oops. Okay, so in our last 15 minutes or so, let me just talk about the most recent study that we've just completed and have done. This is now a study of 63 children and adolescents, documented learning disabilities, with pre and post educational testing and QEEGs. All subjects were randomly assigned to one of three groups now. We've already talked about two of the groups, the resource room and the two-channel coherence training group. Now we've added a third group, in which we did four-channel, what we call multivariate coherence training. And I'm going to explain what that means. And then, of course, we measured the changes in reading scores as the primary dependent variable. In this last group, we also followed math and writing changes, which we had not studied previously. So about 2 years prior to the study, myself with Howard Lightstone from Eager developed a new algorithm to train coherence using 4 channels of surface EEG that we call multivariate coherence training, or quad P-sync, which is what the QPS stands for. If you're interested in the math, this is how the smoothing function is performed on the EEG and how P-sync is evaluated in Eager, which is very similar to what people on other software platforms call pure coherence or coherence. It's just performed with the peaks of the EEG as opposed to the total EEG. From that, we use multivariate combinations of those 4 channels to come up with a coherence metric. So here's how it works. We take the pairwise coherence from A to B, A to C, and A to D. We add those values together, divide by 3, and that's the value of what we call shared coherence from channel A. We do the same thing at channel B, B to A coherence, B to C, and B to D, just like you see here in the equation. Divide that by 3, that's the value at B. So each location now will give you a shared coherence value. The same thing is done at C and D. And these would be your electrode locations. So in the case of a learning disability, A could be O1, B could be T5, C could be P3, and D could be around F7 or F3, or in between that site. when we cover all of those areas. And of course, this is determined by our original multivariate coherence analysis from the QEEG. We then average all 4 of those values, which then gives us a single metric, which is our reward band. And that's what we train. So it's basically an average of all the averages. We developed 3 metrics of this. One called QPS Average, which is what I just described. It's an average of all the averages. And that average changes, of course, goes up and down during the neurofeedback session. And if we want to increase coherence, as we always do in dyslexia, for example, or any learning disability, we're uptraining or rewarding that coherence value to go higher. We have another choice or feedback option called QPS lag that we've studied, which puts in about a ½ second lag before the delivery of the reward, but is still the average of the averages. And then we have a third, which is called QPS deviation, which is an interesting one. QPS deviation takes the 4 channels and it says, okay, tell me the difference between all of these. So if B is a 4 and D is a 2, and that's the max and the min, the value of QPS deviation is a 2. And now we're training, if we want to increase coherence, we want to decrease that deviation or make them more similar to each other. So that's another option in the software as well. Okay, so we have our 3 groups. You can see the age distribution here from about 8 to 16. There's some outliers, but that's basically what it was. We've got a couple questions. I'm just going to kind of get to the end here, and then we'll answer all the questions at the end, I think, at this point. So that's that. Let's see. This is that's the mean in age, distribution of race, medications again, age by treatment, handedness, and gender. Again, none of these variables were significantly different across all 3 of the groups. And the only thing that was significantly different was number of sessions. So when we started using this 4-channel training, the first thing we noticed is people got better a lot faster. So we started doing fewer sessions because we didn't need more sessions. So you'll remember the 2-channel training all had 20 sessions. The average of the 4-channel training group was actually 14 sessions. And that difference is statistically significant. And we'll talk about the meaning of that as we go forward here. Here's all the demographic variables: age, handedness, gender, race, medication, initial reading level. And you can see none of those are statistically significant between the groups. Reading age 1, again, no difference. Reading delay, no significant difference. So in other words, this is a difference between their actual reading score and their age, and there's still no difference between the groups. We then looked at reading age 1 between the groups. There was no difference. Reading age 2 is the same. Change in reading from time 1 to time 2 is statistically significant between the groups. And because our 4-channel group had a different number of sessions than our 2-channel group, we calculated a change per session score. So what does that mean? So if you have a change of, say, 10, and you had 10 sessions, we divide your change by the number of sessions, and we say you had a change of 1 per session. And we do that for all participants, the 2-channel and the 4-channel groups. And then that difference is statistically significant as well. Okay. We then looked at, we could probably skip that one. We then looked at the 2-channel group, specifically compared to the 4-channel group. Number of sessions, there was a significant difference, actually, that you see here. Let me just get my little pointer again, that you see here. That was number of sessions. And when we looked at change per session, that was statistically different as well. So what does that mean? That means that between the 2 and the 4-channel groups, there is a significant difference in reading change scores, which are improvements per session. So what is that difference? Here's the 2-channel group that per session change about 0.6 per session. So what does that mean? So if you were to take a year, 0.06, divided by 0.06, whatever that value is, that would be their change every single session that only lasts about 20 minutes. So that's still pretty good. The 4-channel group is almost double that. And it's about 0.11 with a larger standard deviation going up to almost 0.2 per session. So what we can see from this is that the 4-channel training is faster because it required fewer sessions, and it seems to be more effective, at least in this sample, in terms of improving reading scores in these individuals. Here's the means, and the standard error bar again, when you look at the 4-channel and the 2-channel group, and the distribution. So some of the subjects are similar, but you can see at least half of the subjects have significantly more improvement than the best improvement in the 2-channel group. We then looked at number above 1 month per session. So that would be if in 12 sessions you got a year change, we divide that by 12, and that's 1 month for every session. You're improving your reading scores. If you look at the 2-channel group, 5 of the 21 individuals did that. In the 4-channel group, 16 of the 21 had that level of improvement. Now, that's not to say the others didn't improve, they just didn't improve as quickly. We also then, at the end of this, looked at changes in math and writing scores, because we had those on the educational testing, and looked at those between the groups. And as you can see here, there was no significant difference when you were trained with 4 channels in terms of your reading, math, or writing scores. Now, when you have a combination of different deficits, your protocol may be significantly different, but picking the best protocol possible based on how we've showed you to do that, they're basically equivalent. So this does not just work for reading, we think, but for other educational areas as well. And when you compare 2-channel to 4-channel for the different ability areas, reading, math, and writing, you can see the comparison right there. Okay, so I want to get to just giving you one example, which will kind of conclude the information to present. So this is a 12-year-old with speech and language delays. These are results from a speech language test battery. The mean is 100. Anything below 80 is usually significantly low. You can see there's language deficits. They were 12. These are their reading age equivalent scores. And you can see that they're delayed in almost every area, but their understanding verbal directions, reading comprehension, and reading fluency scores are some of their lowest, in addition to writing fluency. This is what their QEEG looked like. From this, you can see in relative power, some excess theta, that occurs in different locations. And it isn't really focalized for that left hemisphere region necessarily, but we can see a lot in what's probably the semantic area back in here. And then when we look at the coherence, especially in alpha, you can see this whole area right here that's low in coherence. The more these lines are separated, the sensors are separated from each other, the lower the coherence. So again, this includes that whole reading system we talked about. You can see a little bit of it in theta as well. And that's where we decided to train with neurofeedback. So this is what the training protocol design looked like. We were using what we referred to as QPS lag, which we talked about, training it up. These were the sensor locations for the 4 channels. After about 12 sessions of training, these are change scores in coherence. So these orange circles and lines mean coherence increased from the pre to the post QEEG. And we're looking at increases here of 12, 17, 19% over those areas over the left hemisphere where the person was trained. So we would view this neurophysiologically as a very successful treatment. These are changes from pre to time 1 to time 2. So a total of 25 sessions in language scores, which most of which get very close to normal, and reading comprehension scores, which by the end pretty much are within the norm. Remember, she was 12 years old. The age in reading fluency from beginning to end went from 8.9 to 11.9, and reading comprehension went from 8.4 to 11.6. So you can see in this individual, in 25 sessions, you've got a 3-year age equivalent jump in those ability areas. And I've also included references where we've taken this information from in the PowerPoint. We will actually post this PowerPoint on our website, hopefully later today, which is integrated-neuro.com. So you guys can go there and download the PowerPoint and have that for yourselves as well. And if there's any questions, I'm happy to take them now. Okay, so one of the initial questions was, where, how are you referencing and grounding? So one of those questions, I'm sorry. So if we talk about this case, let's go back in so you all can see this. Here, for example, so we have all of our 4 active electrodes on the left side. In that case, the referencing and grounding is very simple. We ground to the contralateral ear, and we reference to the ipsilateral ear. And that's how that's accomplished. You can use a jump link, so all 4 channels don't necessarily have to have 2 or 4 references that get all over the ear, so you can just use 1 or 2 in 1, and that can be set up in the system. To use this, obviously you need a 4-channel amplifier, and previously or currently, this has only functioned in eager software. Right now, Brainmaster software is in the midst of programming this into their software as well, and hopefully that will be available to everyone that has Brainmaster shortly. So the other question was, is the eager system the only one able to train 4 channels? So that has been the case, and we believe BrainMaster is the next one that will program it. And Thought Technology has also shown an interest, but to my knowledge, they have not completed that yet. Okay. Any other questions? Going once, going twice, going 3 times. Oops, I think I see another one. Did you say you are rewarding 1 to 10? So in this particular example, the reward was 1 to 10 in this case, but every case is a little bit different. So that was this case here, where we clearly wanted to reward alpha and theta, and we actually decided that we would go all the way down through delta as well. But each case is individually tailored so that the reward band matches the coherence deficit in the QEEG. And the inhibits, which you see here, we will match the power excesses in the QEEG. Again, keep in mind, if you try to program this with two-channel coherence training, two-channel coherence metrics, you're probably going to get very different information that estimates are in 50% of the cases will put you off target. If anyone wants to learn more about the multivariate type of coherence training, we can certainly help you with that. And the multivariate analysis of EEG data. Okay, another question. Did any of these subjects have ADD? No, in fact, these subjects were ruled out for having ADHD and they only had dyslexia. I will say that we've applied this type of neurofeedback to other individuals, including those with seizures, those with head injuries, learning disabilities, depression, autism, and all of those. And in many cases, they respond favorably. Again, anyone with a major coherence deficit assessed in this way, we think has the ability to respond to this type of intervention. And then there was a question, do you provide 4-channel training to professionals? In fact, we do. And we're actually holding a on-site workshop at our main location in Fayetteville, Arkansas, December, I think it's 11th and 12th, which is a Friday and Saturday. And you can find that on our website as well, if anyone's interested in attending. And what we do in addition to that is we work with people through an online consultation model where we can teach you and train you remotely as well. So anyone that's interested, we can also talk about that. Okay, we're a few minutes over, but we started a few minutes late. If there's any other questions. Will there be future on-site trainings? Well, we certainly, I would say yes. We don't have them planned at this point, but I would imagine the next one would probably happen maybe sometime in the later spring. So this one is in about 3.5 weeks, the second weekend of December. And then I imagine we'd probably plan the next one maybe into April or May or so. So if you want to be on a mailing list, I think we have your information and we can always send you future announcements about that. Okay, next question. What is the difference between coherence and asymmetry? Good question. There's a very big difference between coherence and asymmetry. Asymmetry is a measurement of the difference between power metrics. So for example, if you look at the asymmetry between P3 and P4 in alpha, you're looking at the difference between alpha generated at those two sites. And asymmetry is a measurement of that difference. Coherence is not a measurement of amplitude or power at all. Coherence is a measurement of the relationship between the activity between the two sites within a given frequency, where power has been removed from the equation. So you can have similar power or different power between two sites and have the same or different coherence levels. It's a completely different metric. It is essentially a measurement of if within a given frequency band, two or more sites are doing similar things at similar times. And when that happens, we presume they're working together. The messages are being sent from one site to another. We cannot have any presumption of that based on only a power analysis, only coherence, or variance of coherence measurements can tell us that. Asymmetry does not tell us that. Okay, any others? Oh, okay. How do you determine to use QPS lag versus QPS average? Who gets which? Good question. Up to this point in time, we have been essentially randomly assigning who gets which mode, QPS average, QPS lag, or QPS deviation, because we're wanting to study the effects of each. When we've studied that in a global group of about 170 patients, which was presented at ISNR 2 years ago, there was no significant difference between the three. We are now studying to see if there are differences between the three across different patient groupings. So far, we've completed research studies for learning disabilities, which we just talked about, and depression. And we'll be analyzing if there are differences between the three different modes for those as well. But at this point, we don't make clinical decisions about that, so we can't really provide information about if one affects people in different ways or not. And then the next question is, and hypo and hypercoherence. So I'm going to assume that means, can you use this for either? Yes. You can measure hypo or low coherence or hyper or too high coherence with these multivariate coherence techniques, and you can decide to train it up or down within this 4-channel training model as well. And we've seen the same results for hypercoherence as we see for hypo. It works more efficiently. And in fact, we've had a few cases of individuals with OCD, for example. OCD, as a rule, typically has hypercoherence over midline frontal regions, especially over FZ and surrounding areas. And when we train coherence down for those individuals, their OCD symptoms begin to diminish fairly rapidly. We've also done down training of coherence for individuals with ADHD, where it's relatively common, and for individuals with autism, where it's relatively common. So next question. So for hypercoherence, do you make the hypercoherent area an inhibit rather than a reward, or do you down train? Okay, so the reward band is the only band that measures and trains coherence. The inhibit bands measure and train amplitude. If we want to down train coherence, we specify the frequency band within the reward band, and we then specify to down train that reward band instead of up training it. And that then decreases coherence. Any other last questions? Oh, here's one. Please say that one more time. Okay, I'll try. The reward band is the only band within which we are training coherence. The inhibits that we use, let me move this out of the way so you can see it, are inhibiting amplitude or power metrics. So that would not do it for us. So instead, within an individual that has hypercoherence, say across the frontal lobes, we would pick 4 sites. We pick our frequency where they had the hypercoherence. We put that frequency in the reward band. And then in the reward band, we have a choice to train it up or down. If we train it up, we're going to increase coherence. If we train it down, we're going to decrease coherence. So when we want to down train hypercoherence, we down train the reward band, which down trains the coherence. Okay, good. Somebody understood that, so that's great. Okay, any others? Great. All right, well, thank you all very much for attending. Again, if we can help in any way, you can reach us by contacting Megan, which I think some of you have done, or our website is integrated-neuro.com. And everyone have a great day.